Hello and welcome to Everyday Medicine. I'm Dr. Luke and I'd like to thank you for joining me on this podcast series where we share conversations with colleagues, exploring their special interests in medicine and bringing insights, ideas and advice which I hope will be applicable for our medical practices. In this podcast episode, we're talking with Professor Thomas Jobling once more on the subject of ovarian cancer. Before starting, however, for Australian audiences, listening does give you eligibility for your CPD, so log in and add this as an activity. You may also consider journaling, reflection, and adding to the review and performance section in your CPD. Well, each year in Australia, there are about 1,800 new diagnoses of ovarian cancer and over 1,000 deaths, making ovarian cancer the fifth most common cause of death from cancer in women. The lifetime risk is about 1.6%, increasing to 5% if a first-degree relative is affected. If you have the BRCA1 or BRCA2 mutations, the risk is 45% and 25% respectively. The median age of diagnosis is 63 years, with two-thirds of patients diagnosed at 55 years or older. Histologically, tumour cells may arise from the outer epithelial lining cells of the ovary, 60%, the germ cells, 30%, or sex-cord stromal cells, 8%. Epithelial tumours of the high-grade serous type are now thought to have spread to the ovarian surface after arising from secretory cells at the fimbria of the fallopian tubes, acquiring a TP53 mutation there before metastasising to the ovary as clinically evident ovarian cancer. Well, serous carcinomas represent the vast majority of primary malignant ovarian tumours, that's 75 to 80%, and are composed of columnar cells with cilia. These tumours are subdivided into high-grade and low-grade serous carcinomas, and this has particular relevance for the BRCA-associated ovarian tumours. As with many internal diseases, clinical presentation may be late with vague pelvic discomfort giving way to pain and bloating, and then more systemic symptoms with advanced disease. The tumour marker CA125 may only be elevated 50% of the time in early disease, rising to 80% in advanced cancer. However, false positives may occur with benign ovarian disease, leiomyomas, as well as endometriosis. As with tumour markers used in the follow-up of other cancers, its utility in screening, therefore, an early diagnosis is limited. The disease is advanced in 75% of cases at the time of diagnosis, and 5-year survival is about 41% when local spread is determined, reducing to 30% or less with distant metastases. And this compares to 89% survival or above with early detection when the disease is localised. Well, given the importance of this condition, I was curious to consult with Professor Thomas Jobling once more on the current practices of surveillance, approaches to detection and management, and how to manage risk in first-degree relatives. How should we approach an ovarian cyst found incidentally during abdominal imaging? What symptoms should we be mindful of as clinicians in triggering our suspicion to investigate further? Now, I know you'll find this conversation with Professor Thomas Jobling interesting. Tom is a gynecological oncologist, an ex-AFL footballer and medical researcher with a very respected reputation in Melbourne and internationally. He has extensive experience with minimally invasive surgery, including robotic surgery for gynecological cancer, and his main research area is ovarian cancer, for which he received an Order of Australia Medal in 2017. He's currently Head of Gynecological Health and VMO at Peter MacCallum Hospital. Please welcome Professor Jobling to the podcast. So, Professor Thomas Jobling, thank you for joining me again on Everyday Medicine and to 2025. Here's to a good year. Thank you very much.
Thanks, Luke. Yeah, thank you.
My first interview for 2025, and I thank you very much for our recent conversation on endometrial carcinoma and carcinoma of the cervix. So I really appreciated that podcast interview. And I've certainly learnt, and I'm quite keen on football, and I didn't know this, that you played for Melbourne.
Had a couple of years there and a bad knee injury. So, that was a different life, that's for sure.
Really? One of my friends is a keen follower of Melbourne. Said, yes, he was in Melbourne. Yeah. So you've kept that one a secret, I think, from everybody.
Yes. Probably best to do that, yeah.
I think it's often the case very successful medicos have got successful sporting careers and other careers as well. But we wanted to talk to you about ovarian cancer, which I know is one of your special interests. And it's I think, the fifth leading cause of death from cancer in women, and maybe about 1,800 cases a year in Australia. It's a pretty significant clinical problem for us to be aware of in primary practice. Can you run us through a thumbnail sort of sketch of what we need to know, how it presents, and what we should be thinking about when we present with topics?
The average age of malignant, or at least epithelial ovarian cancer, is in the 50s. Usually about between 52 and 58. It's, as you say, the most lethal gynecological cancer, and the overall survival it has improved over the past 30 years, but it is still, most patients will still die of it, and at least 2/3 of patients present with advanced disease. So in terms of symptomatology, the classic symptoms are so non-specific, such as abdominal bloating and abdominal discomfort, a bit of anorexia, a bit of, maybe a bit of the patient doesn't notice until they feel their tummy's a bit blown up. People like you, Luke, will see these patients sometimes with those gastrointestinal symptoms, and then some imaging is done. It's not uncommon for patients to present to their GP a few times before someone thinks of doing some imaging. Interestingly, some doctors will look at annual screening in inverted commas with blood tests and CA125s and ultrasounds, but there's been pretty good evidence now that actually does make no difference to either incidence detection or overall survival. And even in patients with known BRCA gene mutations, that has not made any difference to overall survival. So we do not recommend people undergo screening in inverted commas. In terms of diagnosis, as I said, the mean age is in the 50s. Interestingly, younger women who develop ovarian malignancies, there are a few patients, but most of those do end up turning to have some sort of genetic abnormality. Most patients who have a non-benign ovarian tumour under the age of 40 turns out to be benign. Most patients who have a non-benign tumour over the age of 40, they are malignancies. 75% of ovarian cancer will be high-grade serous cancers, probably 20% mucinous, and the other 5% will be clear cell, endometrioid, or other undifferentiated type tumours. The way I try and explain ovarian malignancy is that I liken it to like an orange, where you've got the skin on the outside, you've got the pithy bit in the middle, and you've got unless it's a navel orange, you've got the seeds in the middle, and the tumours of the ovary will be epithelial most of the time, but stromal tumours such as granulosa cell tumours do make up a few percent, and then germ cell tumours of the so-called seeds, they're almost always in young women with a mean age of 19. So if we put the germ cell and the stromal tumours to one side, because they are pretty rare tumours, and just think about the epithelial cancers, as I said, most of those will be serous carcinomas, and most of them are high grade. Interestingly, low-grade serous tumours don't respond much to chemotherapy, so they might sound like they're better, but they're actually not necessarily so much better. Diagnosis is classically, associated with, as we said, non-specific symptoms, and then imaging, which will show most patients are in advanced stage at diagnosis, and really only 20% will be early stage 1 or 2. So
can I ask you thank you, just about the histopathology? My reading was, I'm glad you clarified that, but the epithelial cell tumours, are they arising from the fallopian tubes, or are they arising from the surface of the ovary, or is it a mixture?
It's a mixture, and so most people now call it tubo-ovarian primary peritoneal carcinoma because they're all derived from the embryological coelomic epithelium. Now, your question is a very good one, Luke, because in the past, we used to say, 20% of ovarian cancers have a normal volume ovary. Well, in fact, they probably arose from the tube. So 20% of so-called ovarian cancer is almost certainly tubal cancer.
Right.
Histologically, you can't really distinguish them, but we do know that the tubal lesions often start with mutated P53 cells that you can pick up on immunohistochemistry, and then we get a so-called stick lesion or serous tubal intraepithelial carcinoma, and then you get invasive fimbrial cancer or tubal cancer, often in the fimbrial. Certainly BRCA mutations are more often associated with tubal cancers, and so that does have some implication for risk reduction surgery and some of the options there, but we can... Ovarian cancer will turn out to be tubal cancer, and that's an important consideration. And they're all serous tumours. Yeah.
But those tumours arising from the epithelial lining of the tubes, fallopian tubes, are those cells just basically sloshing into the peritoneum, or are they tending to embed on top of the ovary so that they are still appearing as an ovarian cancer, or can it be a mixture of those sorts of problems?
It can certainly be a mixture of all of those things. Occasionally you'll find a tube which is a hydrosalping, so it's a blown up sort of sausage-like thing.
Right.
You take it out and there's tubal cancer inside it, but with no metastatic disease. But often you'll find relatively small volume ovarian cancer in inverted commas, which turns out to be primary tubal cancer, but with tumour on the surface of the ovary, as you've said, but with metastatic disease in the omentum and around the coelomic epithelium all over the peritoneal cavity. Yeah.
Gotcha. Do you have a favoured imaging that you would recommend, like GPs consider? Is pelvic ultrasonography?
Yeah. So if you're concerned, then obviously most patients are going to end up with a CT of chest, abdomen, pelvis, and an ultrasound, because the CT will show free fluid, maybe some mass in the pelvis. But as you know, Luke, CT in the pelvis is not great, and we will often get if a patient's referred with a funny-looking pelvic mass, we'll often get a tertiary level ultrasound done by a gynecological ultrasound specialist. And then obviously a bank of tumour markers, CA125, CEA and CA19.9. If they're very young women, we might add an alpha-fetoprotein, beta-HCG. Some people will do an LDH, although it doesn't really add much. And if it's a solid tumour, we'll sometimes do an inhibin B, because that's a good marker it's an exquisitely sensitive marker for granulosa cell tumours and other stromal tumours like Sertoli Leydig tumours. So tumour markers, primary imaging. Most patients, as you know, when they have symptoms which are really non-specific, will often end up with a CT. I would encourage, obviously, if you're going to do a CT, don't just do an abdo-pelvis, because they've got chest abdo-pelvis, they'll often find fluid in the right lung, in the pleural cavity, and so that will indicate, obviously, high likelihood of advanced disease.
Right.
So the imaging people are now pretty good at picking metastatic disease and stranding in the omentum and things like that. So it's usually, with advanced disease, it's usually pretty obvious.
What's the approach to treatment? Beyond, you've got the diagnosis, I guess. Is it metastatic or is it localised? How do you approach that?
Yeah, so things have certainly changed in my career. Initially, everyone would have primary upfront surgery. So they'd get primary surgery, then they'd be given adjuvant chemotherapy. Now, if patients have disease which is regarded as being less likely to have optimal debulking, where you've got basically no macroscopic tumour, most patients these days are offered neoadjuvant chemotherapy, 3 cycles, then restaging, and then interval debulking surgery. Personally, I think there's maybe a little too much of that done, and a sort of a slightly more nihilistic approach. So I'm a bit more keen on upfront surgery, but I have to declare my bias on that, because obviously when I started, that was basically everyone got that. I think if patients have got stage 4 disease, there's no doubt they probably should get upfront chemotherapy with a view to interval debulking after 3 cycles of chemotherapy. I think most patients should be considered for discussion at a multidisciplinary tumour board meeting, because it does prevent people making maybe arguably unwise decisions about their primary treatment. So I think it should be reviewed and discussed with your peers to get a consensus on what is the best upfront approach. And we certainly do that much more in the public system. In the private system, it's probably less common. Yes. But if there's any doubt, I think that would be an ethical thing to do, yeah.
With the BRCA side of this equation, and that's a minority of people, I'm sure, that are having ovarian carcinoma, although the risk increases significantly. Hearing that fallopian tube involvement is a bit more common, is there ever an idea that we just remove the fallopian tubes in younger women, or leave the ovaries behind?
It's a really good question. There's a couple of things to say. One is that about 18% of ovarian cancer will have a genetic basis, of which 14% is BRCA, 4% probably mismatch repair Lynch type patients.
Yes.
In terms of patients who have an identifiable high risk with BRCA, those patients are now being offered entry into a trial called TUBA WISP, T-U-B-A, WISP, W-I-S-P, where younger women will be offered the option of having laparoscopic self-injectomy with ovarian conservation until they perhaps get a bit older, and then have definitive risk reduction surgery. This, I think, especially in women who have not ever had malignancy. Obviously, if you've got a BRCA mutation, half of them present with having had a history of breast cancer and then get a family history looked at, and then, oh dear, let's do genetic testing. Oh goodness, we've got we've got a BRCA mutation. What are we going to do now? So it's a really good question, Luke, and certainly opportunistic self-injectomy is a thing which is now being practiced around the world. So if women have a hysterectomy for menorrhagia or some other benign condition, they will all be advised to have an opportunistic self-injectomy done at the time to reduce their risk of ovarian cancer, because, of course, the fallopian tubes do nothing in terms of ongoing health, whereas oophorectomy does have a not such a great effect on long-term outcomes, and that leads me to talking a bit about how practice has changed. In the 1980s, there was a gynaecologist called John Studd who practiced at King's College in London, and he came up with what was thought to be a cunning plan to try and reduce the risk of ovarian cancer. And he suggested that anyone over the age of 40 who had a hysterectomy for benign disease should have their ovaries and tubes removed and go on to hormone replacement, estrogen replacement. That would probably save about 10% of lives from ovarian cancer, because if you look historically, 10% of women with ovarian cancer could have perhaps had that done in their 40s and been saved. And then about 25 years later, someone went back and looked at all the data and worked out what overall survival had happened to women over that period of time when they had their ovaries removed, and looked at the incidence and death rates up to the age of 65. And in fact, there was an 8-to-1 survival advantage if you left the ovaries in there up to the age of 65, even though they were postmenopausal. So everyone went, whoa, hang on, okay. So now we do take the tubes out, but we leave the ovaries in until women in their 60s maybe, and that's pretty well standard practice now. So that was a significant change in how we manage benign disease and as you said, self-injectomy. So that's been a good thing, and we have that discussion with women a lot these days. Obviously, people get concerned about ovarian cancer and hormone therapy, and we know that, in fact, estrogen, unless you take it for more than 20 years, probably doesn't increase the risk of ovarian cancer. There was some data which suggested a threefold increased risk. That still only means 3% if you take long-term estrogen replacement, and the beneficial effect on bone health and cognition and every other aspect is very good for hormone therapy.
Yes.
So that kind of covers that bit off.
Tom, so I'm interested in what you advise relatives, daughters of women, non-genetic diseased patients, so don't have Lynch, don't have BRCA, but there's a mother who's got ovarian cancer. Yeah. What do you tell the daughter? And it sounds like screening perhaps isn't that helpful, but I'm just interested to see what you advise.
So that's a really good, and you're very insightful, Luke, because it's a question which I have to address every week of my life.
Okay.
And the data is, even if you've done gene testing and they're BRCA negative, if you've got a first-degree relative with ovarian cancer, if they're under the age of 50 when they got their ovarian cancer, the first-degree relative's risk goes up by 4 times. So it goes from about 1% to 4%. If they're over 50, it goes up by 3 times, so about 3%. So it's not something that you can be dismissive of. And then my discussion revolves around the fact that there is no evidence that screening helps, but you shouldn't deny the patient the option, because on the day that they have that imaging, you can probably say, okay, you probably don't have anything nasty. The problem is that if you look at the WHO criteria for what constitutes a screening test, and I think we had this discussion not in our previous pod, the information would suggest that there are 9 criteria that you need to comply with to have what constitutes an acceptable screening test, one of which is, do you know the natural history of the disease? And the reality with ovarian cancers, we've got no idea. Does it take 12 months? Does it take 3 weeks? Does it take 6 months? I can tell you I've seen patients who had no evidence of disease in August and had widespread disease in November, and that was in a patient who had a laparoscopic cholecystectomy with no evidence of metastatic disease anywhere, and had their lap chole in August. In November, they had widespread ovarian cancer. So almost certainly they didn't have disease at the time of the lap chole. So, it can be very rapidly progressive, and therefore, you kind of don't have any evidence. Now, in terms of screening, there have been 2 major studies done. One was the study done by my colleague Ian Jacobs in London in 1989, where they looked at, I think, 21 or 22,000 self-referred women who had a CA-125, a vaginal examination and an ultrasound day 1, and then 12 months later had the same test done. They picked up, I think, 11 cases of ovarian cancer in that cohort, of which 7 were already advanced, so you'd argue that that didn't constitute any advantage to those women. Maybe 2 or 3 patients with early-stage disease. But for every patient that was diagnosed with ovarian cancer, there were 10 surgical procedures done for benign disease, and that is a serious issue. So Ian was not happy to be dissuaded from that management. So in about 2015, he managed to convince the British government to give him £60 million. And he looked at a very much larger study where there were 100,000 controls, 50,000 had a blood test and 50,000 had the trimodal screening, and there was no evidence of benefit in that study. So we put that to bed well and truly. Ian and his colleagues wrote a paper suggesting a trend. There was an editorial written in the JAMA Journal, Journal of the American Medical Association, which clearly said there is no evidence that this was of any use. Yeah. So, I think the evidence is lacking that screening helps us at all.
Yes, so we have to be empathetic and maybe offer it if someone is asking for a bit, recognise that the evidence is not there.
Correct. Yes.
I'm curious, sometimes we'll do a scan for, in my instance, it might be abdominal pain. We'll find an ovarian cyst that looks a bit complex. Yep. Do you have a rule of thumb for teasing out that? Yeah. How do we approach that?
Yeah, so look, that's another excellent question, Luke. And that's one of my colleagues calls those patients a vomit, a victim of medical imaging technology. and nevertheless, that happens so much these days, and not unreasonably, because, as you say, they're being investigated for...
That's not Jörg Kemper, is it?
Sorry?
That's not Jörg Kemper, is it?
No. It was a guy called Paul Davey, who's a gynecologist up in Ballarat. Basically, it's a really frequently encountered issue, and they do have to be then followed up. So what I do is recommend a tertiary level ultrasound with one of the COGU people, certified obstetrics and gynecological ultrasound specialists, multi-markers, and then often they'll need a repeat scan in 6 weeks, or if there is sinister-looking features, then they'll need a discussion about that, because you're right. I mean, there are fortuitous findings, and some of those patients will in fact be found to have abnormalities, and we see that with women who have a bit of pelvic pain who have an ultrasound. They're 72 years of age and they have a thickened endometrium, and the question is asked, do they need a curette? They've had no bleeding, they're not on hormone therapy. What are we going to do? Well, there's no rule about what you do, but occasionally you'll find endometrial cancer. I don't have a strict policy on what I do. I mean, I have an open discussion with the patient and say, look, your options are, if you're terrified and risk averse, then do a curette. If you're not fussed, then we'll rescan you in 3 months unless you get bleeding, and then we'll default to a curette. In regard to an abnormal ovary, If they're premenopausal and they're still menstruating, then it's highly likely that a lot of those patients will have a functional ovulatory event with a hemorrhagic corpus luteum and a vascular-looking thing. Inexperienced ultrasound people who are not just doing gynae will often interpret those as abnormal. A gynae-oncologist, at least a gynecological ultrasound guru, will probably look at it and go, no, I'm pretty confident that's just physiological. Let's rescan it in 6 to 8 weeks. It's all gone away. You're fine. So I think it's a postmenopausal woman with a vascular-looking lesion with a solid mural nodule and multi-septated complex cyst. That's a different issue. They're obviously a lot more at risk. So menopausal status and the ultrasound appearance and markers will help triage those patients to one form of management. Yeah.
Thomas, thank you for running through that. That's an excellent summary of ovarian cancer. I have one final question, and that is your advice to medical students that are thinking about their career going forward. Do you have any kind of sage words?
Well, if they're looking at obstetrics and gynecology, then they will need to consider the fact that there are very few general obstetricians and gynecologists these days. People tend to go down either obstetrics and maternal and fetal medicine, or they'll go through some form of surgical gynecological subspecialisation. It's another, to be a gynecological oncologist, you've got to go through, 5 or 6 years of specialist training. Then you've got to do another 3 years with a thesis, and it's pretty arduous. When I did it, I did general surgery in England, and I did a doctoral thesis at the Imperial Cancer Research Fund, and then started my ovarian cancer research career. But like specialist training, especially in, you've got to be a very clever doctor to do physician training. So you're in a much higher league than I'm at. But O&G training, it's pretty arduous, and it's getting harder and harder to get in. And that's, I think that's pretty interesting. There are a lot more people training in specialist medicine now. When I started in O&G in the 80s, the population in Victoria was about 4.5 million or thereabouts, and we had 9 trainees. It's gone up to about 6.5 million. We've now got 27 trainees a year. So there's a lot more people specialising in medicine, and I'm not sure whether that's good, bad or indifferent, but it's an interesting observation.
It is the way medicine has progressed, hasn't it? I think less people perhaps doing primary general practice, actually, and more people are putting their hands up for specialty training. And Tom, thank you very much for taking your time.
Not at all.
I hope the share is, one for you, for Melbourne, the Melbourne Football Club. Not sure what's going to happen there, but
fingers crossed.
And really appreciate your expertise time and all your great clinical work. It's been
not at all.
It's been tremendous to have you in Melbourne and refer, complex cases to you and
you're most kind. Thank you very much.
Thank you.
Good on you.
Well, thank you for joining me in that conversation with Professor Thomas Jobling. I found that fascinating and very helpful for my thoughts about how to investigate patients with pelvic discomfort. I hope you've also gained significant insights from that conversation. And next week, we'll be conversing with another very interesting guest. And during the podcast series, we are covering a wide range of topics across many specialty interests. The discussions aren't intended, though, as specific medical advice for patients, but as general information only, and do reflect the opinions of the guests interviewed. Requests for new topics to be reviewed and comments about the conversation you've listened to are welcomed, and may be emailed to manager@gihealth.com.au.